Can you see my screen?
Yes, we can. Thanks, Till.
All right, wonderful. Okay, so yes, so again, my name is Till Bachmann. So I'm the founder, one of the founders of the AMR Futures Lab, and we speak about our collaboration, which we have the Nursing Now Challenge on global solutions and the AMR Futures Lab on the AMR initiative. And really to kick things off, I showed this last time, but I want to bring it back to everybody's mind. This is that AMR is really a wicked problem. It's very difficult to pin down, has so many aspects to it. It spans the human, the animal, the plant, and the environmental domains. And it captured in social, economic, political, and cultural contexts. And it is important because, as you are all aware, but we need to make ourselves aware every day again, is that every antibiotic which we take is somewhere produced. It is transported. During the production are side products occurring, which may end up in the environment. We use antibiotics. Those antibiotics are used on humans, on animals, and on plants. They are coming into contact with the bacteria which we want to address, but also those which we don't want to address. So there are side effects or unwanted consequences. And then the antibiotics end up again by excretion or by disposal in the environment and affecting the environment, the microorganisms in the environment. So there is no action around these antibiotics which have no consequences. Now, it is not easy, as it says here. It's a wicked problem. It's a simple cause and effect considerations are not the easy approach to this, and they are sufficient to adequately create sustainable solutions. The other aspect here is about global efforts to address AMR through research and development have received substantial funding. As you can see here, it's over $1 billion, almost $2 billion in 2022, and over $17 billion since 2017. So these are data from the Global AMR R&D Hub. So it's a lot of funding going in there, and the challenge is we still have AMR as a challenge, but a lot of our research has been active there. So many of these R&D projects do not make it through to the many valleys of death, as it says here, from basic research and development to implementation and impact. And this is why we are addressing the AMR challenge through an approach through the Futures Lab. So here, what we do is we strive to ideate and catalyze holistic solutions to the AMR challenge by leveraging ideas and voices across the full spectrum of the AMR stakeholders. And that is really about doing a transdisciplinary approach, bringing everyone together who has an aspect in the AMR challenge. And this is from people with lived experiences, patients, the community, farmers, people who use antibiotics or are exposed to them, to the innovators in the field, including, for example, ourselves at universities, but to implementers. And the implementers are, for example, the nurses and the midwives who are taking part in this challenge. And it is really to spark unexpected ideas and come up with really novel things, disruptive things, and achieve impact at the end. It's all about impact. Now, the Futures Lab is launched at the Edinburgh Futures Institute, or is setting up at the Edinburgh Futures Institute. And the reason for that is that Edinburgh Futures Institute is an initiative at Edinburgh which brings together transdisciplinary collaboration, or it brings together many actors who can collaborate in transdisciplinary fashion. It also a transsectoral collaboration, so academia with industry, with the public sector, with the government, with the public, and with funders and investors. So it's really about bringing together many actors who have a place for co-design and co-creation and to come up with data-driven innovation. And really this captures the Futures Institute and our lab at the AMR Futures Lab is well placed in there to have local national and global collaboration. And with that, I thank you for now for listening. Good luck with the challenge. And as you see here on the screen, Manish Paul, who is also one of our panelists, so joining us in the webinar, he was our first fellow in the Futures Lab, helped setting it up in 2025. And with that, I would like to hand over to our first speaker. And I'm really, really delighted to have with us Ratna, and Ratna, to hear more about your experiences, unless there are burning questions from my very brief presentation now at the beginning. I can't see anything. Sorry, Ratna, for a second. I can't see a question, so over to you, Ratna, please.
Okay. Hi, everyone.
And Ratna, sorry, Ratna, you have plenty of time, so just kick off. We will be monitoring what's happening in the background, but take your time.
Okay. Thank you so much. Hi, everyone. Hello. I'm Ratna. I'm from Indonesia, and I'm a registered nurse. And right now, I am a hub lead of the Challenges Committee of Nursing Challenge from the Southeast Asia regions. So, ladies and gentlemen, as an Indonesian nurse, I stand before you today to emphasize that the global fight against this antimicrobial resistance, or AMR, is really important. And it will be won or lost on the front line where nurses and midwives serves. Because I have some experience why this is really important, especially in our field where it is applied, where we are the one who not only educate the society, but also we implement all of these, and we are the one who can prevent this MAR to be happen or worsen in the future. So I have personally experienced the tragic reality of AMR. For example, I caring for the tuberculosis patients who failed to adhere to their regimen, resulting in the development of the multi-drug resistance of TB. And that case is really big in Indonesia. Many people got TB. Many people even have this MDR, or multi-drug resistance of TB. I also see the frequent use of the high type antibiotics in my facilities. So, like many patients that I treated, I was a nurse not only in the ward but also in the operating theater as an anesthesia nurse, and also I also served in the ICU. And during the COVID-19 pandemic, I was everywhere, like in every ward who needs me, whether it is in OR, ICU, ACU, and everything. And I also taking care of patients with antibiotics, and they really use this high type of antibiotics, and they couldn't use like the low type of antibiotics. And in Indonesia, the practice of using antibiotics is really common. For GP, for example, like if you go to GP in Indonesia, and I went to the GP because I have, for example, cough or something like that, it is really easy for them to give us like antibiotics. But like in here, for example, in the UK, if you got only like flu or cold or something like that, you don't get the treatment. You like the GP or someone in the GP, they will tell you, like they told me, to go to the pharmacist and take care of the flu by myself. But in Indonesia, they will take care of you and give you antibiotics. Even the type of antibiotics like amoxicillin, it is really still sold freely over the counter in pharmacies, even if there are some regulations about we must not sell antibiotics in pharmacies freely without prescriptions. But still, even in my household, in like my cousins, they still use amoxicillins in their everyday life and without prescriptions, because they thought like this is the medicines that is work faster and better than others medicine like paracetamol or something like that. That's why they still use it, and it is really common. So it shows that it is really crisis, and this is a crisis fueled by both clinical practices and the community habits, especially in Indonesia. So even if like you make something really big here, like in the lab or like in the policy making in the central government or something like that, but if in the implementations you cannot implement it very well, then the dangers still happen. So to truly empower us in this critical field, our role is to be smarter and more culturally sensitive in educating the patients, especially in Indonesia, like where culture, traditional beliefs, and low health literacy significantly affect how society seeks care and uses antibiotics. Like in Indonesia, they are afraid more of something mystical than something like antimicrobial resistance. Even if like there is like educations or maybe health literacy about antimicrobial resistance, why it is really important, why it is really harmful if you're doing this and that, if it doesn't make sense for them culturally, they will not be able to understand and implement it in their daily life. And as frontline nurses, we must innovate our communications to ensure our messages about hygiene and completing prescriptions truly resonate. However, education alone is not enough. We must be supported like by the right infrastructure, meaning we need to have reliable sanitations, clean water, and access to necessary diagnostic tools in all settings. And then, so to prevent that microbial to affect us in the very first place. And also, most importantly, we need strict monitoring for the use of the antibiotics across the entire healthcare system, from the hospital prescribing to pharmacy sales, to curb inappropriate use. Finally, nurses must be recognized and included as stewardship leaders and given a voice in policy making. By investing in nurses' communicative intelligence, providing the right tools, and implementing the strict monitoring measures, you're not just supporting a professions. You are investing directly in the health security of the world. Thank you.
Oh, Till, I don't know if everyone else is having this problem, but I can't hear you.
Oh, can you hear me now?
Yeah, can hear you now.
Sorry. So yeah, I was just thanking Ratna for her presentation, and it was really, really good. Really good to get your insights. And Ratna, you really pointed to many important aspects of the AMR challenge. And if you could come back online, please, then if we can maybe. If you can, if there are any questions from the floor for Ratna, that would be really, really good. We have time to answer these. Ratna, you mentioned plenty of things and plenty to follow up. And you started with the TB aspect to it, and the in TB is the adherence to the treatment protocols and treatment regimen. From your experience in interaction with patients, do you have what's your experience for the reasons why people don't adhere to treatments?
Yes, so after I asked my patients why they are not adhere to these regimens, is because first of all, TB regimen, it takes a long time, and it takes you not only long time, and you need to be disciplined. And it is really hard, like maybe for those patients to be to have that kind of things, because first of all, in Indonesia, the health literacy is really low. So we need to be really careful in educating the patients to make sense to them, because most of the TB patients, they are not only low in health literacy, but also they have low educations, and they have like also from low status of families, status of social status, and they came from like the houses that is really tight, like in one house there are so many people living there. So it's not only first they need someone who need to remind them every day about these medications, and also they because also first about the discipline, and the second because they said like the taste of this medicine is not good, and it affects bad to their conditions, to their they don't feel well after taking the medicine. And also the third, they even we thought we teach them like how to cough and how to not spread this TB to everyone in their house. They still doing it, and it makes like everyone in their house got the TB. They don't isolate themselves, like they don't like making making a good space between their family. And that's why one family come to the facilities because of TB, the other members will come too because of the same problems. And because if like this one family, they are not disciplined, it will cause like the other family got the TB and even got this MDR TB. So it's really hard to make them to have this discipline, to make them understand that this is really important, to make them understand that it will be really dangerous for themselves and the family if they don't adhere to. So this education is a really, really great challenge. And to make them adhere is really great challenge, because it takes a long time, like a minimum of 3 to 6 months of regimen. And even if you got MDR, it will be more challenging because it will take you a longer time, and you need to have like a bigger challenge, like like the other type of drugs that makes you more uncomfortable. And that's why it's really hard to tackle these drugs resistance of TB in Indonesia. And even Indonesia now have like maybe I forgot, but the last time is like the third biggest TB cases in the world or something like that. So I think one of the most important thing is about that adherence, that disciplines, and that the feeling of they got from the uncomfortable of being disciplined and taking care of those regimens, I think.
Excellent. Thank you, Ratna. Ratna, now as you speak, questions are pouring in the chat. Maybe I'll read one out from Elaine about Ratna. Could you say a bit more about appropriate cultural sensitivity and adaptations regarding antibiotics for patients? How might you do it differently to, for example, the UK?
So for the cultural sensitivity, I think we need to see it is very different for us to educate the patients based on their backgrounds. So we need to see carefully what is the backgrounds of the patients. Like in Indonesia, we have more than 1,000 cultures. We have more than 700 languages and tribes. So we need to make sure that they are, for example, if we educate in Indonesia, we need to make sure that they understand Indonesian language. Because some people, they only understand the local language, and we have more than 700 local language. So that is one of the challenge. But like for in the UK, that is also the same. We need to see about how is the understanding of the patients first. Like, what do they think about their about their sickness, about their disease? What do they think about taking care of the medicines? What do they think about this antimicrobial resistance, for example? If they said like, oh, this is something not important, like, oh, this is something mystical, or oh, this might be something because the god hate us or something like that, then we need to like we need to go from that entry. I think like we need to see how to make sure that we don't like against that belief or cultures of the patients, but we need to make sure that in Indonesia there is the name of transcultural educations. So we
Yes,
need to make
yes,
sure to bring culture to our educations, and that is also maybe can be done in the UK. We need to see what is the view of the patients about their disease, about the drugs that they will get, and then about how they think about that, how they manage about it before, and something like that. And then what is the understanding? What is their capacity of understanding, maybe from their educations or how they can
yeah,
comprehend.
yeah,
So from
yeah.
that, we can give the education very well.
Fantastic. And is the would you agree, or would you agree that the nurses have a specific role there in this education because they spend a lot of time with patients? There are in very many cases first point of contact, and that may be in secondary, tertiary care, but also in primary care or even in the community.
Yes, nurses and midwives really
Yeah.
important. Like if you are only the one who make this policy, or you are only like the one who prescribe, you will not understand about this hustle. Like you will
Mm,
only like why we have make like a very good entry a very good drugs, why it cannot tackle TB, what
mm,
is wrong? The wrong
mm,
is not from the drugs, the wrong is from the patients, the wrong is from their disciplines. That is it.
mm,
If
mm.
even if you have a very good drugs, but if you cannot make it consistent, if you cannot discipline in taking it, then that's it, nothing
Yeah.
works.
Mm,
So
yeah.
nurses and midwives are really important in here.
Yeah, you mentioned over-the-counter use of antibiotics as an issue. You mentioned flu. Where would nurses come in this situation? Because they may not be involved with pharmacies directly, or are they? Or how would you? You mentioned antimicrobial stewardship, obviously, as an important aspect. Nurses should have a say on, but how could they impact on over-the-counter use of antibiotics?
Yes, actually, like as a nurse, we have this advocacy. We have the role of as advocators, and this role of advocators is not only advocate the patients. We need to advocate what happened in the healthcare system. We know what happened, but sometimes we have this imposter syndrome that we are afraid to tell what is right and what is wrong. And sometimes, like in Indonesia, for example, we just let it go. We know it's wrong, but we let it go because we feel like we don't have a say. But the thing is, we have it. So that's why we really need to have this support, to have the voice everywhere. We are everywhere. We are the majority of the healthcare
Mm,
professional. But if we don't give our voice, then that's it. We are just numbers, no quality, only quantity. So we need to
yes.
use these advocative roles. So the thing is, if we are afraid to do that, it is not only harmful for the patients, but also for the healthcare system as a whole, and even to the research. Like they don't know what happened in the field because we never report it. We
Mm,
never
mm,
like talk about it,
mm.
something like that. So I think like as a nurse, we are if something like that happen, we can like advocate, we can tell, we can speak, so we can speak up. But sometimes what I see is like, for example, in that pharmacist, there is no nurse in that pharmacist because sometimes it's only like a private pharmacist where the owner is that pharmacist is herself. or himself themselves. And then like in the clinic where the doctors, they gave the prescriptions, like there is a nurse, but they don't have a say. They're only like helping, but they don't have this advocative role. So maybe they have, maybe first, maybe they are not educated enough, or maybe they know, but they don't want to advocate. Just, I don't know why. So this is
Yeah.
something that is really crucial, advocative role.
Absolutely fantastically said, Ratna, and this is why we're here, to make nurses heard, and to bring up the advocacy, and encourage nurses and midwives in this role, and as much as we can contribute to this, but also this is why we are so delighted that we are collaborating with the Nursing Now Challenge. Ratna, thank you so much for now. You spoke a lot, and we could continue with the conversation. But please stay online. Of course, we may come back to you with further questions. But for now, thank you so much, Ratna. And I would like to move on further to our next presenter. Yeah, there are a lot of clapping, and please check the chat, Ratna. There is a lot of thank yous in the chat for your presentation. All right, so I would like to move to our next presenter, and that is Laura. Sorry, where is it? Laura Ahern, and I saw her online for a second. Laura is an advanced clinical practitioner in respiratory medicine in the Northern Care Alliance NHS Trust in the UK. And Laura already asked also a question to Ratna about TB, which Ratna already answered to some extent. But Laura, I will give you the floor in a second. In the moment, we don't see you yet. If you switch on your camera, that will be fantastic. And then we will be very keen to hear about your experience soon.
Can you hear me? Can you see me?
Yes, we can. We can't see you, but we can see some slides from you, which is tremendous.
Right, okay. That's probably better than seeing me, to be honest. I'm just trying to see where I can find the camera. Been having a few technical issues this morning, so I can either just crack on, see if that works there.
We can hear you.
Yeah,
do you have a cover for your camera? It looks a little bit, it's black. It doesn't say that your camera is off.
Why it's off? Just trying to think where else it could be.
We can hear you, so that's
anyway,
okay.
I'll carry on. So yeah, so I'm just going to talk about, my name's Laura. I'm an advanced clinical practitioner. I've been a nurse for 20 years. And I really think that nurses and midwives are the unseen force in IV to oral antibiotic switch. But I think more than that, I think we absolutely have a role, and all general nurses and midwives should have a role within antimicrobial stewardship. Next slide, please. And they're just my disclosures. So next slide. Okay, so how I've arrived in AMS. So like I was just saying, I've been a nurse for 21 years, worked in various departments, emergency departments, district nursing, community matron, just to mention a few. And all of these roles have involved infection, whether you're working for any of these and seeing the patient. So whether you're in primary or secondary care, working in the community or within the hospital. However, I just feel that there's a big gap within education in nurses in the fact that it's not routinely taught about antimicrobial stewardship. Our role can become very task orientated at times. So we're putting up the antibiotics, we're giving the antibiotics, but we don't really understand antibiotics fully. So I always compare it to pain, actually. So if somebody has a headache, we know to give them paracetamol. And if we ask for morphine or something really strong, as nurses, we would question that. However, with antibiotics, I think whatever is prescribed is very task orientated, and that's what the nurses give or administer, because just that gap in education. As we've seen before, everybody's involved in antibiotics, and it's about, it impacts the nursing workload the most. We know that putting up an IV antibiotic takes about 22 minutes, as giving an oral tablet takes about 60 seconds. So actually we can really release the nurse's time by switching from IV to oral. But actually, how can a nurse make a professional challenge if there's a lack of education or a gap in education? So it's about how can we implement this education within pre-registration nursing, post-registration nursing, and maybe mandatory training. That's what I sort of am looking at. We've got the largest workforce, nursing and midwifery. So we're on the unseen force, because actually we can have a massive impact. I think it's really important that we get the correct diagnostics, and I'll talk a little bit more about that a little bit later on, but it's part of our code of conduct. We've got to give the right drug at the right time to the right patient by the right route. So as we know, how can we do this if we've got that gap in education? And if we know that people who have viral infections and we're over-administering IVs, then, it's really important that we can really have that professional challenge. So that's what I've been looking at for nurses. Next slide, please. Okay, so you need to click a few times on this slide. So why it's needed, it's everybody's responsibility. I feel like it's a silent pandemic. In the hospital, they come through A&E, the patients, and there's a real sort of drive for septic patients. If somebody's seen as septic, they get the antibiotics within the hour. But I suppose the concern about that is then how many people do we overtreat, or how many patients with viral infection are getting IV antibiotics who don't always necessarily need them due to the fear of sepsis. So actually, within 48 hours, we should have all of our diagnostics back, and we should be able to step some of these patients down or stop the antibiotics. But actually, what's the nurse's role in collecting diagnostics? Could we be using our triage nurses a little bit more to be able to gather these diagnostics before the IVs are put up, before the oral antibiotics are given? Could we be utilising our workforce differently to make sure that we're using appropriate management? We need a change in culture. The status quo is that it's always been pharmacy and doctor driven, when actually there's a big role for the nurses here, and actually they're the ones that are gathering the diagnostics. So in order to gather good diagnostics, there needs to be an understanding of what the consequences of those diagnostics are, and why are they taking them. So if with the gap in knowledge, then you're unable to, I feel, give the correct treatment because you don't fully understand why you're gathering it. So a sputum sample, for example, what early morning samples, but not just from the back of the throat where it could have colonised. We want it from down at the bottom of the lungs. So actually educating our nurses on gathering good diagnostics is important, and is the start of being allowed to treat these patients. Okay, so we're just going to move on now to how we're going to prompt IV to oral switch. Next slide, please. So as I've already discussed, really want to empower and sort of innovate our nurses to really think, no, nurses and midwives should be leading nurses and midwives. Let's come up with our own solutions. That's what doctors do. That's what every other profession does. So let's stop being task orientated as nurses, and let's really think of our own solutions. Let's get involved with quality improvement. Let's make that a thing that we should be doing, because that's the only way we're going to get that shift in culture, and that's the way we're going to fill these gaps. There is risk averse in decision making. So as previously said, in the newspapers, we often see patients who have not been started on treatment quick enough due to sepsis. But actually, what's the silent pandemic? It's this AMR. If we continue to overtreat our patients, then actually we won't be able to treat them in the future. And I think also as nurses, and midwives, we have a very holistic view of our patients. We see them every day. Sometimes they're anxiety driven. I know with my COPD patients, they might be driven by anxiety, but if they come into hospital due to their baseline being not very good, they might be started on IV antibiotics. But as the nurse, the ACP within that area, I might do some breathing exercises. I might do some, different approach to that patient who has become more breathless with a chronic disease. So it's about holistic nursing and how we can view these patients differently to reduce the amount of medication that's inappropriately given. It shouldn't solely be a medical decision. Or the surgical team, we absolutely need to get on board with this. Next slide, please. Okay, so what are the current challenges? So the job description. There's no job description in the hospitals. We've got currently in an antimicrobial stewardship nursing group. There's 16 members. It is growing in numbers. However, not all of these people have AMS in their job title. It's more of an interest to these individuals, and people who have been seconded are often finding that this secondment is then not being continued because you can't see the value of these posts. It's not measurable always to, see those faster admissions or those antimicrobial resistance where you've prevented a patient. So because it's invisible sometimes, it's difficult to continue getting funding for these roles. Gap in practice, to think I work, there's 4 hospitals. I work over at the Northern Care Alliance, which is 4 big hospitals, and we haven't got one antimicrobial stewardship nurse. I'm doing it as a special interest and get 1 day a week at doing this work at the moment. So just to show you the lack of nurse involvement and midwives, we haven't got any midwives in our group currently. So there is a real gap within involvement on antimicrobial stewardship across the country that we can see currently. If we can bring antimicrobial stewardship as part of the role, and I think every nurse and midwife should have training on this, then we can improve collaborative working. The nurses and the midwives can work with the pharmacists. They can tell them how the patient's been. They can work with the doctors. They can learn from what the pharmacist and the medic says, and they can have that real collaborative working in order to improve patient care and get them through the hospital back home where they do much better. It's going to be proactive versus task orientated. So not just putting up what's prescribed, it's about really questioning that. And I think that we should have a standardisation. By having standardisation, then every nurse, every midwife across the country, across the world, you could say, would know how to see an infection, what we're looking for. We're not asking them to be microbiologists, we're not asking them to be pharmacists, we're just looking at identifying the unwell patient to be able to step them up and step them down, but about them having the correct treatment. And that is from primary and secondary care. So it's about having tools to be able to use so that we can able to do that. And as I've previously said, I think all nurses need educating and midwives to have the biggest impacts on this issue. Next slide, please. Okay, so we're trying to reduce inappropriate prolonged IV antibiotics. What do we know? We know that there's 22% currently of the population that come in and they're on IV antibiotics in the hospital. By only having a very small amount of nurses trained in this, I feel that you're setting them up to fail. And the reason for that is because if one goes off sick or, you want those transferable skills. You want your nurses to be coming from the community into the hospital and they've got the training to know about antimicrobial stewardship. So that is my opinion. By doing this, we'll reduce the nursing workload because actually then we can prevent these inappropriate prolonged IV antibiotics because they're coming from a different angle. They're not just coming from a medication eye. They're not just coming from we're worried about sepsis and what's the consequence of not giving IVs. They're coming from a holistic point of view. They're coming from a point of view where they're looking at as well, if they can reduce the amount of IVs, then they can use that time to do other nursing duties. And actually, it's about upskilling our workforce by empowering the nursing profession. So we're looking then at improving patient flow, less hospital-acquired infections, cost saving and a greener agenda. So it'll have a big knock-on effect by just upskilling our workforce. Next slide, please. So this is where I started. So this is innovation. So this is where I was talking about quality improvement and nurse innovation. So this model came out within our hospital, and I was asked to do a quality improvement on our AMU departments who were sending up lots of patients to respiratory who were on inappropriate IV antibiotics for various reasons. Flu's usually one of them. So looking at, coming in, start smart, absolutely. Start your antibiotics. We're really good at that, but then we weren't very good at becoming focused. So at 48 hours, 72 hours, getting those diagnostic results back, looking at the patient's observations and making the decision to stop or switch. We were having patients on much longer IV antibiotics than 48 to 72 hours. So what did I do? Next slide, please. So by using the national standard of what was expected from us, I adapted it. I adapted the national standard to be used within clinical practice. And I thought the best way to do that was to do a tick box, but also looking at our documentation. If you look at what nurses document when putting up IVs, it's usually IVs as prescribed, IVs administered. Yeah, most of it was administered IVs as prescribed. There wasn't that collection of information which they already gather to make that decision or make that professional challenge. So it's really to get the nurses thinking and the midwives thinking. Okay, so the patient's news, as you can see, is fine. And if you're ticking yes to most of these, then actually the patient is suitable for an IV to oral switch. And in most cases, stopping. But also what this chart does is it also identifies patients that need escalating. So this is standardizing the process so that everybody is looking at the same information to make the decision on whether a patient should be on an IV or an oral, and whether to escalate or to de-escalate. So I think we're very good at escalating at times, but actually nobody should be fully escalated all the time. When do we start to step down? Because that is equally as important to protect antibiotics. Next slide, please. And I think, sorry, just going back there, I also think it's very important to have a rationale. You know, I want to, sometimes reading the notes, the medical notes, I don't know why the doctor's made that decision or why that decision's been made. So at the bottom here, want some comments and decisions. So we don't want just in case the patient goes off. I want a real, you know, own your decision, absolutely own it. You know, we're keeping this patient on IV antibiotics because we're querying meningitis, you know. So then you're really sort of owning your decision making, and patients will get stepped down sooner, hopefully, so that they're not just on antibiotics just in case for defensive medicine reasons. So that's the reason that does. And also it's good for if anybody ever goes to coroners, you know, we can really sort of defend your decision making with good documentation. Next slide, please. So I went down to AMU, looked at the antibiotics patients were on. As you can see, we use a lot of tazocin, and this was done in 2022 on the 7th of November. So these were the IV antibiotics prescribed in our department. Next slide, please. So using these 26 patients and looking at what we should be doing nationally for a formal review of IV antibiotics at 48 hours, none of these patients, unfortunately, met those standards. The information is gathered, but it was never put together to make the decision to continue or step down an IV antibiotic. Next slide, please. Okay, so by doing this baseline audit, and by using the national standard, so I had a look at what patients came in with, what antibiotics they were given, 64% of these patients could have been switched to oral antibiotics if the criteria had been followed. 24% were switched to orals, 8% died on the same day, unfortunately, and 4% had suspected meningitis. So actually, only the 4% really on this was appropriate. Next slide, please. So had a look at what the diagnosis was, so really to break down these patients. So lower respiratory tract infections or community-acquired infections were CAP. So it's a pneumonia, community-acquired pneumonia, cellulitis and cholecystitis. So those were the diagnosis why patients were on those IV antibiotics. Next slide, please. So we implemented change. We give a trial period from the 21st of November, and we utilised the decision toolkit. So put the protocol in the patient's notes. We worked with pharmacy. My initial thoughts were to carry this out with nurses, but just due to the lack of understanding of AMS, I worked with the pharmacy team because more work needed to be done with our nursing workforce. So provided staff education on what we were doing. I did this to the medical team and the pharmacy to engage them to use the decision toolkit. Next slide, please. So again, we implemented this protocol into the notes. Next slide, please. Using an ABCDE approach. Again, looked at the antibiotics prescribed. The microbiologists were interested in this. Again, we have a lot of tazocin prescribed. By just implementing the tool, the protocol, all 25 notes then met the national standard for a formal review at 48 hours. By using this, we were able to switch 48% from IV to oral, 16% of antibiotics were stopped, and 36% of these antibiotics were continued. Next slide, please. Okay, so what's next? So was planning on rolling it out across the Northern Care Alliance. Unfortunately, this role keeps getting stopped and started for various reasons for me, so that hasn't actually happened. Nationally, we have made the resource pack, and that's due to come out very soon. Working with, want to work more with universities, looking at pre-qualification and education, and also nurse education in antimicrobial stewardship, driving a change in culture, and IVOS competency packs for all nurses. So I think my biggest take-home message here is this would improve working collaboratively, empowering the nursing workforce in their involvement in antimicrobial stewardship. Next slide, please. click it again. Yeah. And by doing this, then hopefully we should have a domino effect where we get a reduction in rates of MRSA, C. diff, but then looking at the education needs, investment needs, and the behaviour changes. So there's quite a lot that needs to happen in order to get our nurses involved in this area of stewardship. I think it's going to be difficult, but it's a challenge that needs to happen because this problem is not going away. Next slide, please. Thank you very much for listening.
Thank you so much, Laura. Fantastic. Absolutely great presentation and raising a lot of important aspects. And I mean, the IV to oral switch and the toolkit you presented, I think it's excellent. It's really, really good and leading to some questions, I'm sure. I have one from Fran already, and Fran has this in the chat. And I just read it out. So Fran says she had previously encountered a challenge from senior nursing leadership in large NHS trusts when suggesting that nurses have a huge role in vitro to oral switches, but that is not the role of nurses, and nurses don't have time. So how would you recommend we challenge these views from senior leaders?
Hi, Fran. Thank you for sending today as well. Yeah, absolutely. I've had the same challenge myself, and I wouldn't just say it stops at nurse leaders. You know, I've had pushback from medics saying we don't want nurses involved and they don't want constantly pestering with switching. But actually, if nurses are putting these IV antibiotics up and it's part of their code of conduct, they absolutely should be educated. Otherwise, in my opinion, the medics and, you know, pharmacists should be administering these drugs, because I personally morally think that it's the nurses' duty to know about what they're doing and why they're doing it. It's what fundamentally nursing's about. And, you know, I just quote, you know, we should do no harm. But how can we say that if we're giving medication that's not always needed? So my challenge is, yeah, I absolutely agree. And I've been taken off my role many times, probably for various reasons. But I think, you know, we need to keep pushing forwards because this is a big problem that's not going away. And I think we just need to keep pushing it and keep presenting. You know, and I know from my point of view, it's been very difficult within the trust, and that's why it's brilliant to be able to be speaking here today, and also to have the support from Fran as well, to be able to keep pushing this forward, because actually it can be very, very difficult. And I think it's for various reasons, multifactorial, isn't it? You know, people protecting their own roles, but also sort of, you know, it's the status quo. People are scared of change, but I just think personally, nurses should absolutely know what they're given and why they're giving it, you know, otherwise they shouldn't be doing the job. And I think either they need to own it fully or let somebody else do the job, because, and I know that we haven't got the staff to be able to do that. So I think the only way we can move this forward is by educating nurses and empowering them to enable them to be making these professional challenges.
Very good. Thank you so much for the response. So we take time for further questions. We have a few more minutes in the webinar. The question for myself, the aspect of not enough time, and you said something about task-driven aspects, and it's diagnostics. So I'm doing research on diagnostics, and we always talk about point-of-care diagnostics and bringing this out where the patient is, the bedside testing. My question to you is, how does that go along? And you mentioned diagnostics as an important aspect. How would this go along with not enough time for nurses, what we just discussed? Does it help new technologies, or does it add to the workload and it has a detrimental effect potentially?
Yeah, to be honest, Till, what I think we should be doing is actually, I was a triage nurse in A&E, and actually, why have we not got point of care testing absolutely in triage? You know, it's a really good opportunity before the IVs get put up, before the antibiotics are given. Why have we not got in triage them doing point of care testing? Because actually, some of those patients you could absolutely be spinning around and getting them out. And actually, that would be saving much more time than them coming in. You going through all your clocking, you know, doing all of your tests, and you know, how much time does it take then to put the IVs up? You can't always get the cannula in. Some of these patients, when they're shut down, you know, are very difficult. So I think our point of care testing would save a lot of time and would lead to safe and more appropriate care. Yeah, that'd be my opinion on that.
That speaks to my heart, yes, and yeah, absolutely. And if you were involved in designing such a point of care, where would you put an emphasis on?
Oh, A&E, absolutely. So I was, sorry,
Yeah.
so I worked in the community and I've worked in the hospital. And I think in the community, was a lot more holistic. So I would do breathing techniques with patients. I'm going to talk about patients with chronic lung disease now. So you do breathing techniques with them. You would look at mindfulness, you would look at anxiety and depression. They come into the hospital with the same symptoms, the same things wrong with them. They get IV antibiotics, they get oral, they get oxygen, they get a nebulizer. And I think that is really driving home that they should be in hospital, when actually what we know is that this patient's getting to end stage lung disease. What they really need is management of anxiety and depression. And actually it's their baseline. So I think we reinforce this very invasive treatment with these patients in hospital because we're worried that the septic. I think in the community, we manage these patients very, very differently, in my opinion, in my experience. So I think A&E would be my point, A&E and GP surgeries as well. I think, these frequent flyers, especially as patients get more unwell and get more sort of, somebody with a chronic disease or multiple issues, multiple diagnosis, who are driven, if say anxiety is a driving factor, they're going to the GP all the time, just being able to do that point of care testing and saying you haven't got an infection, or, it's just part of the progression of your disease, this is your new baseline, would be much more, and it's actually then getting into the patient's mind that this is their new baseline of where they should be at. It's preparing them, I suppose.
Thank you. Excellent to hear your perspective on that. And you just mentioned as they go increasingly to the GP or seeing the GP, that is most likely also the case as the patient grow older. Can you comment a bit on the elderly patient population and the importance of the nursing input there?
Yeah, so the elderly population. Yeah, I think as well, thinking of diagnostics, but I think about our elderly population, but really thinking about how they present, looking at for those clinical features. So have they got a temperature? Are they tachycardic? Are they confused? Are they presenting differently? So I would really be looking at history taken there. Let's get a good history from them. Let's not just jump to infection, because they might be constipated and you're treating them for an infection. There's many reasons why people can go off when they're elderly. But also, I just want to touch on your end of life patients. I think for me, as a nurse, and I've been in many conversations, and it is a bit contentious, but identifying a dying patient. So should we be treating these patients all the time with antibiotics, prolonging the dying process, when actually what they really need is good end of life care? If somebody's getting a pneumonia and they've had 6 pneumonias, they've got a stroke and they've got heart failure, we're in my opinion, we're prolonging that sort of agony and that sort of end of life, when we should be really saying, actually, let's symptom manage this patient, because that's the right thing to do, and that would lead to a more dignified death, let's say. So looking at our palliative care patients, but also with our elderly patients, really taking a holistic and detailed history to make sure that there's nothing else going on. Constipation is a massive factor that you see being misdiagnosed or not being identified. So yeah.
Thank you, Laura. And again, really, really fantastic insights. And we could continue chatting about this. And as we same with Ratna, whom we could bring back in if we had more time, but we don't, unfortunately. So Laura, thank you so much for your presentation and contribution. It's so vital that we have this these debates and raising the voice of nurses in the discussion around AMR. Addressing the AMR is important. Advocacy is important, and getting all the expertise and the experience of nurses and midwives into the mix of solutions for this is so important. So I don't see any burning question in the chat from people. I have seen that Hannah has put in a link on the competition, so where things can be submitted, your thoughts, and we are really looking forward to your submissions in the field, and also we are looking forward to further contributions from the participants in the upcoming webinars. But for now, Laura, thank you so much again for your presentation. We spoke about insights. I hope we can see you at another future occasion. Unfortunately, we didn't today for technical reasons, but that is okay. We heard lots of your presentation. We had the slides, and fantastic. Thank you so much again. And if there is a final comment, maybe from Hannah from the Nursing Now Challenge on how we move forward.
Hi, Till. Thank you so much. Thank you for this wonderful session. Thank you, Laura and Ratna. I know she's had to step away. Oh, I can see Manisha's here. Hi, Manish. Thank you, everyone, for taking part in today's session. It's been really, truly fascinating. And you can find the recording on our YouTube channel later today. As Till said, I've popped a link in the chat there with all the information that you need if you want to take part in this Global Solutions Initiative. We're having another session on the 16th of December. If my memory serves me right, it's at 9:30 a.m. And we'll be joined by Professor Aisha Holloway, our former Programme Director and now Chief Nursing Officer for Scotland, as well as a whole host of other fascinating speakers. So please do join us. And yeah, I think that's it, Till. Manish, I don't know if you want to come in with a last word. Okay,
You're muted.
next time.
Okay.
You so much.
Thank you so much, Hannah, and thanks everyone, and see you next time. All right.
Oh, thank you. Bye-bye now. Bye-bye.
Bye.
Bye.
Bye, Laura.